Ladies and gentlemen, thank you very much for attending the APASL 2024, the Center of Hepatology. Now we would like to start our conference program. Now we start the first session, Biliary5, Immune and Target Therapy for Cholangiocarcinoma. Moderators, please.
Good morning, everyone, and welcome to the Biliary session of immune and target therapy for cholangiocarcinoma. I'm Naoki Sasahira from Cancer Institute Hospital of Japanese Foundation for Cancer Research, and my co-moderator is Keisuke Tateishi from St. Mariana Medical University, and also Professor Tai David from National Cancer Center, Singapore. As you know, cholangiocarcinoma is one of the major cancers, especially in the Asian regions. And so we have to do, all the attendees have to do something about this difficult malignancy. And this time we invited 5 speakers for the keynote lectures, including 1 clinical and 1 basic in each. And 3 are real-world data analysis for the treatment and CGP examinations. So very attractive presentations, I expect. So please, I want to move on to the first keynote lectures by Dr. David, and his title is Recent Advancement in Immune and Target Therapy for Cholangiocarcinomas. Please state.
Thank you, Mr. Chairman, for the kind introduction. Good morning, ladies and gentlemen. It is truly my pleasure to be here in this beautiful city of Kyoto. I would like to thank the organizing committee for this invitation and Prof. Isayama for inviting me here from Singapore. I will address the recent advancement in immune and targeted therapy for cholangiocarcinoma and opine its relevant future perspectives. This is my disclosure slide. Between 2010 and 2018, combination of gemcitabine and cisplatin was the only systemic therapy with high-level evidence, and post-2018, multiple agents are available, including immune checkpoint inhibitors and various targeted therapies. Combination of chemoimmunotherapy now defines systemic therapy naive advanced biliary tract cancer. TOPAZ-1 randomized previously untreated advanced biliary tract cancer patients to receive either durvalumab, which is an anti-PD-L1, in combination with gemcitabine cisplatin for 8 cycles, followed by maintenance durvalumab, or to chemotherapy for 8 cycles. The primary endpoint was overall survival. Combination of durvalumab, gemcitabine, cisplatin improved median overall survival compared to control with a 20% reduction in the risk of death. The survival curves separate at 6-month mark and widens with time, with a 24-month landmark survival approximately of 25% in the durvalumab arm compared to 10% in the control arm. Adverse events of any grade more than 10% in either treatment arm were comparable and driven largely by chemotherapy. Any grades immune-mediated adverse events for durvalumab-containing combination was 12.7%, and grade 3 or more immune-mediated adverse events was 2.4%. In a separate trial of a similar study design, addition of pembrolizumab, in this case an anti-PD-1, to doublet gem-cis chemotherapy was superior to chemotherapy alone, consolidating the role of immune checkpoint blockade in this setting. Treatment intensification involving combinations of immune checkpoint inhibitors with chemotherapy are being evaluated. While achieving its primary endpoint of demonstrating an improvement in progression-free survival, albeit modest, no differences in overall survival was gleaned with combination of atezolizumab, bevacizumab, and gemcitabine and cisplatin. This efficacy signal, however, was enhanced when limited to patients with VEGF-A high expression, underlying the importance of a biomarker-driven approach. Perhaps the future in biomarker could lie in the employment of artificial intelligence. AI-powered whole slide image analyzer was used to segment tumor epithelium and stromal and identification of intratumoral TIL and stromal TIL utilizing tissue specimens of 339 patients with advanced BTC treated with anti-PD-1 monotherapy from this study conducted in Korea. Immune phenotype was classified as inflamed with high intratumoral TIL, immune excluded with low intratumoral TIL and high stromal TIL, and immune desert with low overall TIL. The objective response rate, median progression-free survival, and median overall survival was highest with the inflamed tumors determined by AI-powered spatial analysis. Considering the efficacy of chemoimmunotherapy in advanced BTC, investigation of its utility in the earlier setting is the logical next step with a number of enrolling trials. A number of strategies beyond combination of immune checkpoint inhibitors with chemotherapy have been envisioned, including CAR T in the advanced setting. Shifting gears now to BTC have a heterogeneous molecular profile, and this is both anatomic subsite, etiology, and geography dependent. Molecular alterations as such provide avenues for targeted therapy. IDH1 mutation occurs in approximately 20% of patients with intrahepatic cholangiocarcinoma, which results in accumulation of oncometabolite 2-hydroxyglutarate, which blocks differentiation. Treatment with ivosidenib led to a 63% reduction in the risk of death or progression compared to placebo in pre-treated IDH1 mutant advanced BTC. FGFR fusions are present in 20% of patients with intrahepatic cholangiocarcinoma, and this leads to a ligand-independent activation of oncogenic downstream signaling pathway. A number of pan-FGFR inhibitors have been evaluated in previously treated FGFR2 altered biliary tract cancer with an objective response rates of between 20 and 38%. Off-isoform toxicity and on-target resistance, however, limit the benefit of these pan-FGFR inhibitors. Relay 4008, a highly specific irreversible FGFR inhibitor designed to overcome these limitations, and in a preliminary analysis of 17 patients, the objective response rates was reported to be 82%. Up to 20% of biliary tract cancers overexpress HER2, and there are a number of efforts in place targeting HER2 with heterogeneous inclusion criteria, and varying strategies have been employed with agents such as trastuzumab deruxtecan, zanidatamab, and combination of tucatinib and trastuzumab particularly intriguing. MDM2 amplified p53 wild-type accounts for up to 6% of individuals with intrahepatic cholangiocarcinoma. In a phase 1 study of which included 2 individuals with BTC, brigamadlin afforded an objective response rate of 11% with a 74% disease control rate. And the author reported in the publication of a 51-year-old male with MDM2 amplified cholangiocarcinoma. And following 3 lines of systemic therapy, he received brigamadlin 80 mg once a day with achievement of partial response by day 22, which was still evident on day 360 with a maximal tumor shrinkage of -73%, and the patient remained on treatment for 13.3 months. 3 to 5% of BTCs possess BRAF V600E mutation, and combination of dabrafenib and trametinib in this pre-treated group of patients yielded an objective response rate of 47%, with a median progression-free survival and median overall survival of 9 months and 14 months, respectively. NTRK fusion is rare in BTC. Both larotrectinib and entrectinib have demonstrated efficacy in NTRK fusion positive GI malignancies, including BTC. And similarly, pralsetinib has demonstrated efficacy in RET fusion malignancies, with RET fusion being present in less than 1% of BTC. In the same publication, the authors describe a case where a patient with intrahepatic cholangiocarcinoma with RET fusion, having received 3 prior lines of systemic therapy with progressive disease within 3 months for all 3 systemic therapy, who then went on to receive pralsetinib, with achievement of partial response with maximal reduction of 77% in the measurable disease for 20.7 months before ultimately succumbing to progressive of disease. Adagrasib and glasiracib have demonstrated activity in KRAS G12C malignancies, including BTC. And of note, in a small subset of patients, 12 patients with BTC had an objective response rate of 42%, median progression-free survival of 11 months, and median overall survival of 15 months when treated with adagrasib. As of any targeted therapy, acquisition of secondary resistance limits its therapeutic potential. For example, treatment with FGFR2 inhibitor would inevitably lead to emergence of polyclonal secondary resistance, typically in the FGFR2 kinase domain. And many of these resistance are either gatekeeper mutations, example V565I, that prevent binding of FGFR2 inhibitors through steric hindrance, or molecular brake mutations that led to ligand-independent kinase activation. Tinengotinib targets an FGFR binding site away from the inner pocket to avoid impact of these mutations, and this overcomes the acquired mutation from the first-generation FGFR2 inhibitors. Hence, transitioning a patient from first-generation to a later-generation FGFR2 inhibitors could be clinically meaningful for a proportion of patients. The use of targeted therapy in biomarker-defined BTC is currently limited to systemic therapy pre-treated patients. Its role in systemic therapy naive advanced BTC deserves evaluation. However, efforts in developing infigratinib in frontline setting has been instructive and sobering. Over 40 months, a total of 1,127 patients were pre-screened at 120 sites, with only 48 patients being enrolled. Poor accrual underscores the challenge of conducting biomarker-driven studies in subpopulations of BTC, and this study has since been terminated. Combination of IO plus targeted therapy with or without chemotherapy is a logical next step, and combination of gemcitabine with oxaliplatin, toripalimab, and lenvatinib conferred an impressive objective response rates of 80%, with a median progression-free survival of 10 months and median overall survival of 22 months in a non-biomarker selected advanced BTC. This, however, resulted in a grade 3 toxicities of more than 57%. This strategy deserves further development. Of importance, single-cell transcriptomics and TCR profiles of 18 pre- and post-therapy tumor specimens treated with this regimen were perused. High proportions of CD8 granzyme B positive and CD8 proliferating cells predicted good response, with a transition of CD8 proliferating cells to CD8 granzyme K positive facilitated a favorable response. In contrast to that, macro CD5L positive and CD8 granzyme B crosstalk impaired the efficacy of this regimen by CTLA-4 upregulation. So to conclude, ladies and gentlemen, IO in combination with chemotherapy is the current standard of care in the first-line setting. However, much work needs to be devoted to find out who benefits most from this regimen, with further development of alternative immunotherapies are warranted. Targeted therapy in biomarker-defined patients are efficacious in second line and beyond. Study of secondary resistance mechanisms important to devise new targeted strategies. I thank you, everyone, for your kind attention.
Thank you, Professor David. And we have 7 minutes for free discussions. So any questions from the audience? Okay.
Thank you, David. Excellent talk about the summary of the recent therapy. So I'm Isayama from the Junto University. So the background of the cholangiocarcinoma is so various. So you mentioned. So we mainly manage intrahepatic and extrahepatic cholangiocarcinoma. So recently we can use nilotinib or pembrolizumab for these cholangiocarcinoma. But how do you think about extrahepatic cholangiocarcinoma? So these therapies are really effective, please give your opinion about effectiveness of the treatment.
Thank you, Prof. Isayama, for the question. I just wanted to clarify. Your question was whether combination of immunochemotherapy is effective in extrahepatic cholangio. Thanks for the question. In both the TOPAZ 1 as well as the Keynote study, and when they look at the forest plot, it tended to favor the combination of chemoimmunotherapy for all anatomic subsites itself, except for gallbladder cancers. But gallbladder cancer was a very small subset, so it remains difficult to truly understand its efficacy. But I think it is not impossible to envision that patients with different anatomic subsites could have varying differences in terms of response and the control itself. Inherently, we know that patients with the different anatomic subsites have different molecular makeup as well as immune infiltrates. So I think much more work needs to be devoted in trying to understand who benefits most, whether it's within anatomic subsite or the underlying genetic makeup of these patients. I hope I answered your question.
Okay. One more question, okay?
Yes.
Yeah. So our idea is so ICI is effective after the broken cancer cell. So then many doctors think the effectiveness of concomitant therapy about the radiation or radiofrequency ablation to block the cancer cells. How do you think about matching such kind of treatment with the ICI?
Sorry, the question is combination of radiotherapy?
Combination, yes.
With, yeah. So this is a great question, and it's something that a lot of doctors are very excited over. I think everyone in this room realizes that there's a limit to the effectiveness of immunotherapy in biliary tract cancers. There's actually an immunogenic ceiling. I think the first cut is looking at the molecular profile. We would probably understand that only 10 to 15% at best are immunogenic and will respond very well to it. The rest of the patients, 80 to 85%, would need some form of help, and radiotherapy is actually one form of help. Other forms of help would be perhaps radiofrequency ablation or anything that would release the neoantigens. Now, I think further work needs to be done in order to try to understand whether this additional step of radiotherapy would incite this sort of response, and even what type of radiotherapy. Is it the normal fractionation or is it a hypofractionation? I'm just providing experience in terms of another tumor type, which is hepatocellular carcinoma. I think hepatocellular carcinoma immunotherapy has been used widely and is highly efficacious for a larger number of patients, but they remain a group of patients that don't really respond very well. And people are starting to integrate radiotherapy to this group of patients. But from my experience, the modality of the radiotherapy and the timing of radiotherapy also makes a difference. I truly believe that hypofractionated delivery of radiotherapy, whether it's before or after immunotherapy, could best be for hepatocellular carcinoma. Is it the same for biliary tract cancers? I think we need to do more studies and understand the impact of radiotherapy to this group of patients. And one thing that we can do, besides looking at tumor profiles, is also looking at the sequential dynamic changes in the PBMCs to try to understand what has happened in the patient after each treatment has been given. So these are some of my thoughts.
Okay, thank you very much.
Thank you, Dr. Isayama. Next, President Omata, please.
Omata, wonderful. And so many different kind of the treatment is coming. Then what's the situation in your country about the CGP, in other words, comprehensive genomic profiling? Because we have the now support from the government. We can do the foundation one, the foundation one. So since you said that there is a need for the biomarker because so much of the drugs coming in. So how do you apply, and what's the situation in your country about these CGP systems?
Thank you for the question. Unfortunately, Singapore is still behind Japan. The government does not give incentive or reimbursements for the conduct of comprehensive genetic profiling in biliary tract cancers, primarily because it's a very small group of patients. However, when possible, we would counsel patients with regards to sending the tumor tissues or even having their blood profile in the upfront setting, in the advanced setting. There are two avenues. Out of pocket for foundation one in Singapore is 1,500 Singapore dollars. There's another avenue which is non-commercial, which is research-based, our in-house OncoMind panel. So these are two avenues for patients to have the tumor profile.
You know, maybe in Japan there is a coverage, so maybe the patient only pay $20 from the pocket. But the problem is that got to be, you know, tested at the very end stage. In other words, after a repetition of the treatment, then you got to do it. So there is not much of a time to be treated, even though you got the target mutations. So that's our problem. But if you do earlier, maybe the tax money is so huge, got to repeat so many times. So that's that problem in our country. Thank you very much.
Thank you for the comment. And in my practice and in my institution's practice, we tend to do it upfront. Of course, we are selective. Patients who we think with poorer organ function, who wouldn't go beyond first line, we probably won't offer the test. Patients with smaller volume of disease, whom we think would have first, second, and even third line treatment, and these are a group of patients that we try to identify early, such that we can plan the treatment course earlier. For example, if I can detect a patient, if I have a female in her 40s with FGFR2 fusion alterations, and this is a patient who would have a better prognosis naturally because the patient have FGFR2 alteration and could potentially get on the first generation, second generation FGFR inhibitors with meaningful prolongation of life.
I think it's a balance between the length of the life and then how much money you
Certainly,
put in. Yeah.
certainly.
Yeah, very big problem and very important discussions. So thank you, David.
Okay, so we move to the second lecture. We invited Professor Hayato Nakagawa from Mie University. So title is, title is here.
Yeah.
Okay, please, Professor.
Thank you, Professor Tateishi, and I'd like to thank for this great opportunity to talk here. So I will talk about biliary tract cancer from the aspect of basic science. And first, I would like to talk about biliary regeneration and ampullary carcinoma. And in the second part, I would like to talk about a recent study about personal medicine for cholangiocarcinoma targeting lipid metabolism. So now, cellular origin of biliary tract cancer is a current topic. In general, cholangiocarcinoma is considered to originate from biliary epithelial cells, including cholangiocyte. But recent several studies suggested hepatic progenitor cell, hepatocyte, and also peribiliary gland cells in the extrahepatic bile duct also can be cellular origin of cholangiocarcinoma. So identification of the cellular origin of cancer is important for understanding of carcinogenic mechanisms. Here, I would like to, we are now focusing on the peribiliary gland, PBG, we call it as PBG. PBG is a cluster of epithelial cells residing in some causal area of large IHBD and EHBD. And this is H staining of mouse extrahepatic bile duct, and arrowhead indicates PBG. And similar structure is observed in human biliary tract. And until recently, PBG has been considered as just serous and mucinous exocrine gland, but recent studies suggested peribiliary gland may be a biliary stem cell niche, and as is the case in the intestinal crypt, biliary tree stem cell reside in the bottom of the PBG and supply new cholangiocyte from deep side to the surface side like that. However, so far there is no conclusive evidence because of a lack of PBG-specific markers. So we have sought to identify the PBG-specific markers and now we are focusing on AXIN2, that is the target of Wnt beta-catenin signaling pathway. We crossed AXIN2 gray ERT mice and Rosa log-stop logs TD tomato reporter mice. We call this mouse as AXIN2 tomato mouse. In this mouse, we can label AXIN2 expressing cells red in tamoxifen-inducible manner. And these panels show the axial slice of mouse common bile duct and periampérole region. That means distal end of the bile duct. And as you can see, peribiliary glands are much more abundant in periampérole region compared to common bile duct. And the lower panel shows the expression of tomato reporter at the 2 days after tamoxifen administration. And as you can see, tomatopoietic cells are distributed across both luminal surface and the PBG, but in the periampérole region, AXIN2 positive cells were restricted to the lower part of PBG, but not present in the luminal surface. Therefore, AXIN2 is a specific marker for periampérole PBG. So from now on, we will analyze the behavior of these cell types. So next, we perform the linear tracing of AXIN2 positive periampérole PBG cells. And as you know, in this mouse system, cells are labeled genetically. Therefore, divided cells also express tomato reporter, so we can trace the fate of labeled cells. As I showed before, at day 2, tomatopoietic cells were restricted to the lower part of PBG, but over time, tomatopoietic cells gradually extended to the luminal surface of the bile duct, and finally, 180 days later, almost all biliary epithelial cells were replaced from tomatopoietic cells. So we confirmed this finding three-dimensionally. This slide shows the transparent whole layer scanning of periampérole region, and this is at the day 2 after tamoxifen administration. And tomatopoietic cells were restricted to the PBG and not present in the luminal surface. And also we could confirm all PBG connected to the into the lumen. And 180 days later, almost all biliary epithelial cells were replaced by tomatopoietic cells. So these findings suggest AXIN2 positive PBG cells function as biliary epithelial stem cells and supply new cholangiocytes from deep side to the surface side like that. So next we have new question. How local Wnt beta-catenin activation is maintained in the lower part of periampérole PBGs? So we examined various kinds of Wnt ligands, and we found Wnt activator R-spondin-3 was specifically expressed in surrounding smooth muscle cells, that is corresponding to sphincter of Oddi. So we generated smooth muscle cell specific R-spondin-3 knockout mice by crossing MH gray ERT mice and R-spondin-3 4-cross mice. And R-spondin-3 knockout diminishes AXIN2 expression in the PBG. And surprisingly, AXIN2 knockout induced shrinkage of ampulla of fata like that. We could confirm such kind of microenvironment in human periampérole region using surgically resected samples. So R-spondin-3 is secreted from adjacent smooth muscle cells that corresponding to human sphincter of Oddi, plays a critical role for maintaining the biliary epithelial stem cell niche in periampérole PBGs. So as you know, biliary stricture is a common complication after pancreatic duodenectomy, PD. So in PD, periampérole region, including sphincter of Oddi, is completely resected. So I think biliary stricture may be caused by impaired biliary regeneration due to removal of the sphincter of Oddi-mediated biliary stem cell niche. So I think this highlights the clinical importance of this study. Furthermore, we generated PBG-specific P10 knockout mice by crossing AXIN2 gray ERT mice and P10 4-cross mice, and all mice developed ampullary carcinoma. So AXIN2 positive PBG cells function as cellular origin of ampullary carcinoma. In addition, Wnt inhibitor LGK974 markedly suppressed ampullary carcinoma development. So Wnt signal activating niche plays a critical role in ampullary carcinoma development. So this is summary slide. And the new findings can facilitate the development of new therapeutic strategies to induce biliary regeneration as well as to treat ampullary carcinoma. And also recently we found a PBG-specific marker in common bile duct, that is OLM-FM4. So now we are analyzing the behavior of these cells in common bile duct, and this study will be continued. So I would like to move to the next part. So as I showed by Dr. David, recent human genetic study about biliary tract cancer showed TGF-beta, RAS, and PI3 kinase pathways are frequently altered. And based on the mutation profiles, we tried to generate various cholangiocarcinoma mouse models. For example, biliary epithelial cell specific KRAS D12D P10 knockout mice developed intraductal growing type extrahepatic CCA, ECCA, like that, and also intrahepatic CCA. On the other hand, biliary epithelial cell specific P10 knockout and TGF-beta R2 knockout mice developed periductal infiltrating type ECCA, but not developed ICCA. And moreover, KRAS D12D TGF-beta R2 knockout mice developed neither ECCA nor ICCA. So these findings suggest the site and morphology of CCA differ depending on the genetic mutation in mice. And from these findings, we consider the P10 deletion is very important for cholangiocarcinogenesis, at least in mice, and we analyze its role more deeply. So we performed RNA sequence analysis using P10 TGF knockout extrahepatic CCA tissue and compared to control bile duct, and we found lipid synthesis pathway was significantly upregulated. And as you know, P10 knockout induces activation of PI3 kinase AKT pathway, and SRBP, that is a master regulator of lipogenesis, is downstream of this pathway. Therefore, SRBP-mediated lipogenesis, upregulation of SRBP-mediated lipogenesis is as expected. So next to the role of SRBP-mediated lipogenesis in cholangiocarcinogenesis, we additionally knock out of SCAP that plays a critical role in SRBP-mediated lipogenesis and analyze the effect on the cholangiocarcinogenesis. And surprisingly, additional SCAP knockout markedly suppressed extrahepatic cholangiocarcinoma development, suggesting SCAP SRBP pathway plays a critical role in extrahepatic cholangiocarcinoma development. So to further analyze the molecular mechanisms, we cultured extrahepatic bile duct organoid from P10 TGF Frocrox mice and P10 TGF SCAP Frocrox mice, and induced gene recombination using CRE-expressing lentivirus, and generated P10 TGF knockout organoid and P10 TGF SCAP knockout organoid, and performed RNA sequence analysis with control organoid. And as you can see, we found ferroptosis pathway was significantly upregulated in P10 TGF knockout, but significantly downregulated in P10 TGF SCAP knockout organoid. So I would like to explain about ferroptosis. And ferroptosis is a new type of ion-dependent programmed cell death, and hydroxyradical produced from AT2O2 through Fenton reaction induces lipid peroxidation of cell membrane phospholipid bilayer, and accumulation of lipid peroxidation induces membrane rupture and subsequent cell death that is called as ferroptosis. And the cells have also defense system against ferroptosis, and among them, GPX4 GSH system is the most important one. So GPX4 can remove lipid peroxidation in GSH-dependent manner and can prevent ferroptosis. And previously, this is a little bit complicated. We previously reported SRBP plays a critical role in membrane phospholipid composition. As you know, phospholipid has two fatty acids here, like that and like that. And saturated fatty acid has straight structure such as palmitic acid, while polyunsaturated fatty acid, PUFA, such as arachidonic acid, have bent structure at the double bond like that. Therefore, PUFA containing phospholipid can create a space between phospholipid, and that makes membrane fluid membrane like that. So fluid membrane is very important for cell growth, cell division, and EMT that are beneficial for cancer cell. And SRBP can promote carcinogenesis through promotion of PUFA synthesis. However, recent studies showed PUFA-enriched membranes are highly susceptible to repeat peroxidation. Therefore, we hypothesized SRBP-activated cancer cells may have high risk of ferroptosis. So we analyzed the expression of PUFA-containing phospholipid synthesis pathway. For example, FAT1 that is involved in PUFA production, and LPCAT3 that is involved in PUFA incorporation into phospholipid were significantly increased in PTEN-TGF knockout organoid. And also GPX4 that is anti-ferroptosis defense was also upregulated in PTEN-TGF knockout organoid. And such an expression pattern was cancelled by SCAP deletion. So taken together, SRBP activated cancer cells promote carcinogenesis through synthesis of PUFA containing phospholipid, and that increases membrane fluidity and cell growth, and but at the same time increase the risk of lipid peroxidation. And also SRBP activated cancer cells can prevent ferroptosis by upregulating GPX4. So these total effect lead to extrahepatic cholangiocarcinoma development. So if so, inhibiting GPX4 can induce ferroptosis and may prevent cholangiocarcinoma development. Actually, although this is a preliminary data, human ECCA cell line TFK1 that has hemizygous loss of PTEN was very sensitive to GPX4 inhibitor. Therefore, we consider SRBP activation is a double-edged sword for a cancer cell. And the GPX4 is balancing to pro-oncogenic, but inhibiting GPX4 changes the balance to the anti-oncogenic by inducing ferroptosis. Therefore, therapies targeting ferroptosis may lead to personalized medicine for PI3 kinase pathway activated extrahepatic cholangiocarcinoma. So finally, to analyze the clinical applicability of our mouse experiments, we analyzed human extrahepatic cholangiocarcinoma samples, total 182 samples. And as you can see, PI3 kinase and the SRBP pathway and the ferroptosis pathways were highly correlated with each other in human extrahepatic cholangiocarcinoma. And also GPX4 expression was significantly associated with SRBP pathway activity. So these findings further support the clinical applicability of our mouse experiments. And another important thing is that cancer with loss of PTEN is basically resistance to immunotherapy. Therefore, hopefully, our new treatment strategy may be effective in such patients. Thank you for your attention.
Thank you, Professor Nakagawa, about the stem cell and genetic background of cholangiocarcinoma. Any question or comments? Professor Omata, please.
I heard your talk several times, and then every single time you are putting a lot of data and then publish. So you are very productive in a sense that making the experiment. But in a meeting like this, how to fit overall figures, into the current understanding of this area. So my understanding at the very last moment is that the PTEN knockout or loss of the PTEN, such as similar to the TP53 loss, nobody is able to tackle its itself. In other words, no drug against the TP53 loss, just like the P10.
Yes.
So that's why you are trying to see the downstream effects. In
Yes.
other words, you try to find out like SREBP,
Yes.
and then also another molecule. That's the target.
Yes, I
That's
think
you
so.
are aiming.
Yes.
So maybe for your sake, and then as my student, for the future's sake, change the kind of mood of the presentation. In
I
other words, these are the all clinical people. So just adjust it. And then, but in the real scientific,
Yeah,
meetings, please. Then I really think, I really want to see what's the new development of by Dr. Nakano.
I'm sorry.
Very simple story about that.
Yes.
Such a well-established scientist, but that's my comment.
Thank you so much.
Yeah, but I think so. Maybe you have a strategy, so you combine your data to the clinical scene. For example, so stem cell governs the cell lineage. Maybe you get some marker in clinical scene for targeting biliary cancer. Also, if you get PI3 kinase activation in biliary cancer, maybe you can think about rapamycin and GPX4 combination can be possible for biliary cancer. So what is your strategy or your future direction?
Yeah, as you said, PI3 kinase activated cancer cells is very difficult to treat, and in our experiments, SREBP is a very important downstream target. However, SREBP has various kind of roles in all cells. Therefore, targeting SREBP is a little bit difficult. Therefore, we focused more downstream target GPX4, and inhibiting GPX4 can induce ferroptosis specifically in SREBP activated cancer cells. Therefore, I hope this new strategy will be a good personalized medicine in the future.
Okay. Okay, thank you, please.
Thank you. I'm Elena Palma from the Roger Williams Institute of Pathology, London. Very interesting data. I have a question regarding the influence of diet or alcohol use on SREP-P1 and how this can influence then the development of cholangiocarcinoma.
Yes. When we use another kind of cholangiocarcinoma model, high-fat diet markedly enhanced intrahepatic cholangiocarcinoma development, especially intrahepatic. Therefore, I think, for example, fatty liver environment may promote not only hepatocellular carcinoma, but also cholangiocarcinoma. Therefore, I think dietary habit or exercise is also very important to prevent cholangiocarcinoma development.
Thank you.
Thank you so much. Okay, thank you for Dr. Nakagawa. So please.
Okay, the discussion is getting more heated and exciting, and I will next invite Professor Takashi Sasaki to describe to us the real-world data of immune and targeted therapy for cholangiocarcinoma. Professor Sasaki, the stage is yours.
Thank you, Chairman, for introducing me. I'm Sasaki from Cancer Institute Hospital. First of all, I'd like to thank President Professor Shina and the organizing committee to giving me a chance to present our data in this wonderful meeting. My topics today is real-world data of gemcitabine, cisplatin, and durvalumab combination therapy for advanced biliary tract cancer. This is my disclosure. As you all know, biliary tract cancer includes several types of cancer. This cancer is the 6th leading cause of cancer-related death in Japan, and more than 80,000 patients died annually. Surgery is considered as the only treatment for cure, but prognosis of advanced BTC is still dismal, almost about 1 year. So more effective treatments are required for advanced BTC. Gemcitabine and cisplatin combination therapy has long been the standard of care for advanced BTC, but recently GC plus durva combination therapy showed longer survival compared with GC by TOPAZ-1 trial. GC plus durva combination therapy has been approved by insurance in Japan, but treatment outcome in clinical practice are still limited. So the aim of this study is to clarify the treatment outcome of this combination therapy for advanced BTC in clinical setting for Japanese patients. We retrospectively analyzed consecutive patients with advanced BTC who were treated with this combination therapy as first-line treatment between March and October 2023 at our institution. Here shows the Tobas-1 regimen. GC and durva is administered up to 8 cycles for about 6 months and move on to durva maintenance therapy. During the study period, 51 patients with advanced biliary tract cancer were treated with gemcitabine, cisplatin, and durva, and 26 patients were first-line naive case. 16 patients were first-line but converted from gemcitabine and cisplatin, and the others are listed like here. And in this study, we included 2 cohorts, here and here. So 42 patients were included in this study. Here shows the patient characteristics. Median age was 67 and maximum was 82. Performance status 0 was 60%. Intrahepatic cholangiocarcinoma were included 36%, which is slightly lower than the global study. And recurrent cases were included in 40%, which is slightly higher than the global study. Here shows the treatment outcome and response rate and disease control rate were 90% and 81%. Median progression-free survival was 5.6 months and median OS was not reached. These treatment outcomes are almost the same as Tobas-1 trial. And this slide shows the treatment status at data cutoff timing. 60 patients were continued first-line chemotherapy. Among them, 3 patients received durva maintenance therapy. Half of the patients were suspended first-line chemotherapy due to tumor progression, and 2 patients, 5%, received conversion surgery. The patient who progressed by first-line chemotherapy, 2/3 of the patients received second-line chemotherapy, mainly S1. Adverse events were listed here. Because this regimen included gemcitabine, cisplatin, cytotoxic agent regimen, so myelosuppression were observed as previously reported. Only 1 patient were complicated immune-mediated adverse event, and which is adrenocorticosteroid insufficiency. Skin rash is observed in 19 patients, which might be IMAE. I'd like to show some cases. First case is 62 years old male ICC with Lynch syndrome. He started to receive gemcitabine cisplatin, and after 4 cycles, durva is added. And after additional 7 cycles of GCT, we considered conversion surgery. This is a preoperative image after 4 cycles of GCT and additional GCT, 8 cycles of additional GCT and portal vein embolization. Both primary tumor and lymph node metastasis showed marked shrinkage. And PET scan, PET CT shows also good tumor shrinkage, and SUV max decreases from 17.83 to 3.4. CA19-9 also decreases after added to durva to gemcitabine and cisplatin. We finally achieved a pathological CR in this case. No visible tumors were observed in the surgical specimen. He received this surgery last October, and we checked the CT this month, and there is no recurrence yet. The next case is 57 years old female GB cancer with bulky lymph node metastasis. She received GC durva, and after 6 cycle, primary tumor and bulky lymph node metastasis shrink. But after 6 and 8 cycle, primary tumor progressed slightly. This is a CA19-9 trend, and CA19-9 decreases at first, but increase slightly. At this time, after 8 cycles of GCD, we discussed which we should select durable maintenance therapy or continue gemcitabine and cisplatin, and we choose GC in this case. There are several clinical questions remain in this GCD regimen. One is a treatment strategy after 8 cycles of GCD. In cases with good tumor shrinkage and small tumor volume with GCD, we choose durable maintenance therapy. And in cases in which conversion surgery could be considered, we select conversion surgery. But how about cases with no tumor shrinkage with stable disease and high tumor volume after 8 cycles of GCD? Is durable maintenance therapy is okay, or we should continue GC or GC durable or change to second-line chemotherapy? This is a big clinical question, but we need to clarify this problem in the near future. I also want to show another case. This is a 74-year male hydrocholangiocarcinoma case, and he complicated malignant biliary obstruction and inserted 3 plastic stents like this. And we need to exchange plastic stents, so we added RFA during durable maintenance therapy for local therapy and maybe abscopal effect. He received this procedure last month, and we were going to check the evaluation with tumor efficacy next month. Second clinical question is how to manage tumor progression during durable maintenance therapy. Cases with good tumor shrinkage to GCD and cases maintain stable disease with GC plus D, but worsen after the maintenance. Cases maintain tumor control for several months by durable maintenance. GC has remained tumor efficacy. We restart GC containing regimen like GCD, GCS, or GC. But if the GC has lost tumor efficacy, like cases converted to D maintenance with exacerbating trend, we need to consider second-line chemotherapy. How about second-line chemotherapy? FOLFOX is evidence-based treatment for second-line chemotherapy in advanced biliary tract cancer, but this regimen is not covered by insurance in Japan. So in Japan, in the clinical practice, S1 is widely chosen. But in the patient who has a chance to receive matched therapy based on comprehensive genomic profiling testing, the patient should be receiving that kind of matched therapy. So I believe it is very, very important to perform CGP testing before or during first-line chemotherapy. But if the patient do not have a chance to receive these kinds of matched therapy, GCS or clinical trial might be the option. So in conclusion, although this data, our data is only a primitive clinical data, but GC and plus durable combination therapy has shown the efficacy and safety for the treatment of advanced BTC even in clinical practice for Japanese patients. The advent of immunocheckpoint inhibitor has shown the possibility that some cases of advanced BTC can be cured by only medical therapy. And this is a dream of medical oncology, I think. But there still remains several clinical questions for the use of GC durva combination therapy, which should be clarified in the near future, like how to manage the after 8 cycle of GCD, or how to manage durva maintenance, tumor progression after durva maintenance therapy. So thank you for your attention.
Thank you, Prof. Sasaki, for the wonderful presentation. I wonder, we have 3 minutes. I wonder whether anyone has any questions from the audience. Yes, please.
Thank you so much for the presentation. Any good news in cholangiocarcinoma is exciting. I'm a gastroenterologist from southern India, and based on our population, we tend to have about 60 to 75% of our cholangiocarcinoma patients are hilar. So just practically, I was wanting to know how many of your patients actually can undergo chemotherapy at all. Do a lot of them have jaundice? Because I would understand that jaundice would preclude any of this. Do many of your patients actually go for chemo, or what's your scenario?
Thank you for a nice question. And maybe most of the patients could be treated by chemotherapy in our hospital, because our hospital is a big cancer center, so many good condition patients will come to our hospital. But we need to manage difficult hilar malignant biliary obstruction, and we need, for example, I show the case, and we insert several plastic stents, and after that we treat it.
Do you use RFA, biliary RFA commonly, or is that just
Only
rare?
a selected patient, but we want to try RFA for abscopal effective in the case of ICI.
And do you keep a cutoff of 5 bilirubin for chemotherapy, or do you have a cutoff? How do you decide?
We cut off to bilirubin 3.
May
Yes,
I?
Professor.
Yes. This is a question to both David and Dr. Sasaki, because you are belonging to the big cancer institute, Singapore and Japan. And then if you take a look at all the trials, and then you show us a paradigm of the whole sorts of the clinical trials. So, we are talking about the loss, drug loss in Japan, and then maybe we are shortage of the clinical trials induced in our country, maybe because of the pharmaceutical companies. So I want to have your comments about the Japanese, because he belongs to one of the biggest cancer institute, but still the clinical trials is limited. So those situations, could you explain? I want to have your comment and then your response.
Sorry, I just wanted to clarify the question. The question is availability of clinical trials in the institution?
Yeah.
Yeah, that remains a challenge for our institution. The current trial that we have enrolling in the phase 3 setting is Tourmaline, which is actually a phase 3B from the Topaz 1 itself. And we also have an FGFR2 study. But, as you rightly pointed out, so the pharmaceutical companies will go to countries that have a large whereby the population has a large representation of biliary tract cancers. In Singapore, as a result of biliary tract cancer being uncommon, is not a favorite site. So therein lies the problem whereby it will be very challenging for clinical trials to come to us in comparison to countries with huge population, potentially with this condition like Japan and Korea, we lose out. So your point is that it will be very difficult for trials to come to Singapore for us to participate. There are other ways for us to try to get ourselves out there, doing more translational work, trying to understand, the preclinically, bringing back what we see in the clinic with this regimen and going back to preclinical to try to understand a little bit more. So that's our strategy, but your point is very well taken. We are a small population. We only have 6 million in Singapore. Trials seldom come to Singapore, especially given that Singapore is becoming more and more expensive to run trials.
So I hope that your institute become a favorite of the companies, in a sense. But I understand that your cancer institute is doing only a phase 1, right? Mostly,
No,
Dr. Kitano is a main investigator. That's my understanding.
yes.
So how do you think? How about your comments? I mean, you want to do many clinical trials.
I want to do the large clinical trial, but I don't have so much power.
Well, you got to be very influential. Thank you very much.
Yes.
Thank you, Dr. Sasaki, and
Thank you.
we'll move on to the next presentation. The next one is by Dr. Susumu Hijioka from National Cancer Center, Tokyo, and his title is Optimal Sampling for CGP in Cholangiocarcinoma. So please start.
Thank you for Chairman. My name is Hijioka, and first of all, I appreciate for the Professor Isayama and Shina to giving me the chance a wonderful session. So my talk about optimal sampling for CGP in cholangiocarcinoma. No CY. Comprehensive genomic profile testing is now an essential part of cancer treatment. This slide shows the current status of CGP testing in Japan. Since the insurance approval of CGP testing, 67,000 people have receiving CGP testing to date. This graph shows the number of tests by site of carcinoma. Biliary tract cancer is the third most frequently tested carcinoma, indicates a high expectation for CGP by patient. Biliary tract cancer is now area of interest in CGP. It is because there are many druggable genetic abnormalities in biliary tract cancer. As you know, genomic profiling of biliary tract cancer vary widely by site. For example, the intrahepatic bile duct is most common, the FGFR2, IDH1, the BRAF mutation. However, the extrahepatic bile duct or gallbladder is FGFR2 is low, and HER2 and BRCA mutation is high. So in this site, ICC is most important. This is because druggable genetic abnormalities are often found in ICC, especially the FGFR, IDH1, HER2, BRAF, BRCA also. Also, the FGFR inhibitor, several insurance-approved therapies available in Japan, and they are very highly response. So FGFR should not be missed. There are two types of method of CGP. One is to collect from tissue, and the another one is a liquid biopsy. This table shows the advantage and disadvantage of tissue and liquid biopsy. As for the invasiveness and the turnaround time, it has an advantage for the liquid biopsy because the invasiveness is low and the TAT is very short, as short as 3 to 4 weeks. However, most importantly, in general, fusion genes are considered to have a low sensitivity by liquid. In fact, FGFR2 fusion gene is significantly low sensitivity in liquid biopsy, 1.4 by the ctDNA versus 4.3 by the tissue. So to find the druggable gene in biliary tract cancer, especially the FGFR2, it is important to perform the CGP from the tissue. Only when it is impossible to submit for the tissue, so it should be performed a liquid biopsy. Here is a table of the CGP testing using the tissue available in Japan, MCC OncoPanel Foundation 1, and recently we can get again mine by the Todai panel. However, all of these panel examinations required many tissue for CGP. So can USTA specimen be used for CGP? As endoscopists like us, we want to perform CGP by USTA if possible. So what is USTA require in genomic error? This is our hospital data, CGP success rate by needle type and size by the pancreatic cancer. CGP success rate, it means the MCC OncoPanel. The most highest one is 19 gauge with FNB needle. However, it is only the 56%. So we select the needle in our hospital, R and BR, borderline resectable biliary cancer biopsy using the mainly the FNB 22 gauges. However, the UR, unresectable biliary cancer, especially to consider the genomic testing, we usually select the FNB 19 gauges. So how should we collect tissue for ICC? There is two mainly types in ICC. One is a mass-forming type, and another one is a PI type. So the mass-forming type is easily to get tissue, especially for the left lobe from the stomach view. So this movie shows using the 19 gauges, so it can get so many tissues. India, from the Eye Cancer Center hospitals, data revealed that US data, the main USFNA performed mainly the intrahepatic cholangiocarcinoma, and the sample adequacy is target is liver is or adequacy is more than the 84%. And the needle type is 19 gauges is most best is for the target needle. So, however, in the other hand, the PI type, especially the high stricture, this is very challenging. So usually we perform the transpapillary biopsy, or recently we can get the USTA by the FNA needle. So which is better for CGP? Recently, we usually perform the USTA for even for the higher stricture using like this the milk mouth for the plastic stent. This is a movie for the real in the USTA for higher stricture. Avoiding, this is a mass and this is a cystic duct. Avoiding the cystic duct and milk mouth for the plastic stent, we can perform the USTA. This case is using the 22 gauges needle. So this is our hospital data. This is not this is immature data. Transpapillary biopsy versus USTA in higher stricture for CGP. 35% for the transpapillary biopsy and USTA for the performed 46%. The success rate for CGP is transpapillary is very low, less than 10%. On the other hand, the FNA, FNB perform the success rate is more than 30%. However, it was very low, only about 30%. So this is a challenging issue in the future. So the summary, to avoid missing the FGFR2 fusion gene, CGP for cholangiocarcinoma should preferably be performed on tissue. So MF type, especially the left lobe, is a good indication for USTA. Increasing the success rate for PI type, especially the hilar region, is future challenging. Thank you for your attention.
Thank you for your presentation and question from audience. We can get a sample by percutaneously in the hepatic cholangiocarcinoma. And do you usually do the EFTA for the region?
Thank you for your question. Of course, most important is for patient. So especially for the right lobe, we firstly select the percutaneous biopsy.
Mm-hmm. Okay, please.
May I? Wonderful effort to make tissue available.
Thank you.
Maybe something related to the next speaker, but we in our institute, we can do the sequence by ourselves. In other words, whatever you get it, we can sequence it. In other words, when you try to take a tiny bit of the tissues, but in addition, you can flush, you can get the liquid, through the needle.
Yes.
Then one time we compared whether the tissue is more giving the data about the mutation, hotspot mutation, or the flushing the needles and then get the liquid. So it's a sort of liquid biopsies. And then quite interestingly, even though you try to a little bit bigger tissues, but in comparison with the flushing or the rows, the smears,
yes.
Almost comparable. So not necessarily sticking yourself to try to get the bigger tissues, but rather the needle by itself may contain still a lot of DNAs which use the information about the mutation derived for the tumor. So maybe we can make the full use of the sticking things. And then in addition, usually if you say liquid, it doesn't contain the bile juice or any other material except the plasma mainly. Sometimes ascites or pleural effusion included, but liquid is plenty. So that's my just simple suggestion and experiences.
Thank you for your wonderful comment. And also, I surprised to see the Professor Oyama's data. It is only the flash specimen can get the good CGP result. So we hope it will be used in the worldwide review.
Yeah.
Thank you so much.
Please.
Thank you. Thank you for your nice lecture. I have one question. Please mention success rate of transpapillary biopsy was lower than USDA. Why? Please mention your opinion, because.
Thank you for your question. You mean why is the USTA is better compared with the transpapillary for CGP? Yeah. Thank you. The transpapillary biopsy, mainly we usually use small forceps. So that is why the CGP success rate is less than 10%. However, if we use a bigger forceps for the hilar stricture, sometimes we are afraid to the perforation. So I think the more safer method is USDA to see by the US. So the US success rate is more feasible.
Thank you.
Thank you.
I want to ask about EFTA for the higher strictures. Do you usually do the EFTA for the initial diagnosis, or do you do the additional examination for the CVP?
Thank you so much. Initially, we will try the transpapillary. However, if even the diagnosis cannot perform, so we try to the salvage USDA for diagnosis. Additional, if possible, for the unresectable case, we try to the more tissue for CGP.
At the time of the failure after the first line treatment?
Yes, for CGP, for CGP, yes, we try as much as possible to get that tissue.
Yeah. After the treatment failure, the tumor becomes large, so you can get it more easily.
More easily, yes, yes.
Okay, thank you.
Right.
So thank you, Dr. Hijioka.
Okay, so we last speakers. The speaker is Dr. Hiroshi Oyama from Chiba University, also in Yamanas Prefectural Hospital, Yamanashi, right? Okay, so title is Genetic Evaluation by this. Oh, it's just like this. Okay, so please start your talk.
Thank you, Chairman. Good morning, ladies and gentlemen. My name is Hiroshi Oyama from Chiba University Hospital and Yamanashi Central Hospital. I'm very pleased to participate in this session as a speaker. Today, I would like to talk about our research on liquid biopsy of bile in pancreaticobiliary cancer, PBCA. There is no COI for this study. PBCA is the most difficult cancer type with very poor prognosis. According to Japanese cancer statistics for 2022, pancreatic cancer, PC, ranks fourth among all cancer deaths. And biliary tract cancer, BTC, including cholangiocarcinoma and gallbladder cancer, ranks sixth. The incidence and deaths of both have been increasing recently. Longitudinal landmark studies have elucidated the molecular profile of PBCA. They provide the catalog for selecting immune and target therapies. This study is the Know Your Tumor registry trial and shows the significant longer survival in the match therapy group than in other therapy groups. This study indicates that matched therapy is effective even in refractory cancers such as PC. This study also demonstrates the importance of matched therapy for BTC. Pemigatinib is a selective, potent oral inhibitor of FGFR1, 2, and 3. This drug significantly prolongs survival in patients with FGFR2 fusion gene. Therefore, the genomic information need to be applied to select treatment for PBCA. However, it is difficult to obtain tumor tissues because the burden of those tumors is usually very small, and we can get it a little. Therefore, an alternative to tumor is needed for genomic profiling in PBCA. Tumor-derived DNA can be released into the bloodstream from primary tumor, circulating tumor cells, and metastatic lesions, and we can use liquid biopsy. The method have been reported to be effective, more effective than clinical sequencing, but its sensitivity is still a bit inadequate and needs some improvement. Because bile is exposed to tumor, and it contains tumor cells shed from tumor cancer cell, we can use bile as a cytological specimen. As bile is expected to be a liquid biopsy with higher sensitivity and specificity than plasma. However, only a few studies had been reported in a small sample size. So this study aimed to confirm the utility of bile in the era of precision medicine. A total of 87 patients were included in this study. Bile was obtained from 87 patients and plasma from 38 patients. Bile was centrifuged to obtain supernatant and precipitate. Each sample was examined. 41% of bile cytology were class 4 or 5. 82% of patients had BTC. Almost 60% of patients were in clinical stage 3 or 4. We have created a PBCA panel covering 60 significantly mutated genes for genomic analysis that were used in this study. The library preparation was made using the Ion Amplific Library Kit Plus, and the template preparation was made by the Ion Chef system. Sequencing was performed by the Ion Proton system, and raw data was annotated by the Ion Reporter. Sequencing data was annotated with reference to OncoKB. Once the data were obtained, the genomic profiles of bile and plasma were compared. First, the amount of DNA was examined. The amount of bile supernatant DNA was 1,450 nanograms. Bioprecipitate DNA was 2,484 nanograms, and plasma DNA was 64 nanograms. There was a significant difference. On sequencing data, biosamples were superior to plasma in both on-target rate and mean depths. But the sequencing quality was adequate for all samples. This slide is hard to see, sorry. This figure shows genomic profiles of bile and plasma in 87 patients. The left column lists the mutated genes. This left column lists the mutated gene with corresponding amino acid changes. The pink letters indicate oncogenic mutation. The variant allele fraction is shown in the box was indicated by a graduated color scale from 1% light blue to 100% dark blue. In 38 patients who had both samples, the detection rate of oncogenic mutation was 55% in bile and 24% in plasma. The distribution of mutation was shown. In the 38 patient, 111 mutations were detected, and 50% of oncogenic mutations were shared with both samples, while only 2% of non-oncogenic mutations were shared. So oncogenic mutations were shared than non-oncogenic mutations. In oncogenic mutations, the variant allele fraction of bile is higher, significantly higher than that of plasma. So its results suggest that bile contains more tumor cells than plasma. In comparison of bile and plasma by clinical stage, bile was more sensitive than plasma, significantly better overall. 56% of bile had oncogenic mutation, and 24% of plasma had oncogenic mutation. For cancer type, bile was significantly higher sensitivity than plasma in BTC. PC also shows bile is more sensitive, but in PC there was no significance. This table shows the liquid biopsy results by cytology class. The higher the class, the more likely oncogenic mutation is to be detected. Finally, the detection of drug match mutation is here. 80% of bile had drug match mutations, and 13% of plasma had drug match mutations. In conclusion, liquid biopsy using bile may be useful in the search for targeted therapy in PBCA. Thank you for your time. Thank you.
Thank you for beautiful data. So any question, comment? Okay, so you said biliary tract cancer is more, the efficacy of DNA extraction was better than pancreatic cancer. So how about among the biliary tract cancer? So your cohorts include extra and intra and gallbladder fat and so how is it different among the small groups?
Thank you for your question. In the BTC, we had more extra bile duct cancer, and the intrahepatic cholangiocarcinoma was rare. So the result is that.
Okay, so yeah, sometimes for example, in extra biliary, so some tumors mass forming, but some tumors so invasive in the some mucosal. In that case, so that type affect the efficacy.
Yes, maybe the mass forming is more sensitive, but we don't examine the type of the mass, so I can't explain it.
Yeah. Okay. So yeah, we have some one question from. Okay. Okay. So
Dr. Sasaki, please.
Thank you for your attractive presentation. I'm Sasaki from Cancer Institute Hospital. When we discuss about liquid biopsy using the blood, the chips due to aging is sometimes a big problem. How about using bio? Is it chip affect the result?
Thank you. This examination is this study is performed by tumor normal pair analysis. So we don't the chip is not affected in this data. I think.
Thank you.
And we have one question from online and about the FGFR fusion in bile or plasma. As your data, maybe no FGFR mutations, and maybe that's because the target is almost extrahepatic regions, and you get the bile during a ERCP for biliary obstruction case, for no very rare case for the intrahepatic cancer. But do you have any data about FGFR fusions?
Thank you for your question. Unfortunately, we can't detect fusion, so another examination is needed, and no FGFR2 mutation is detected in extrahepatic cholangiocarcinoma.
Okay, thank you.
Okay, with that, I will bring this session to an close. Thank you, Professor Oyama. And I will also want to thank the rest of the speakers for the excellent delivery of the talks as well as discussion. I will thank my fellow moderators for guiding the discussion. And thank you to the members of the audience for coming early and posing some of the questions. With that, I bid you farewell and do come back at 10:50 for the next Biliary6 session. Thank you everyone for your participation.
Thank you very much, moderators and lecturers.
Thank you very much.
Now we will have 17 minutes break.
はいはいはいはい、お願いします。